Picture this. You have a patient sitting right there in your exam room. They have a documented history of Prinzmetal angina, and for exactly 6 months, they have been rigorously compliant with their prescribed calcium channel blocker regimen.
Hmm.
And the clinical picture is just fantastic. I mean, their symptoms are perfectly controlled, zero exertional chest pain, zero midnight waking in a cold sweat with that, that crushing classic variant angina presentation.
Yeah, the terrifying one.
Exactly. Their ECGs have totally normalized.
Mm.
And then they look at you and ask the question that, frankly, every clinician faces with the distinct sense of unease in this specific scenario. They ask, can I stop taking these pills now?
Oh, it is the ultimate pivot point. It really is. You're in what otherwise feels like a routine, totally victorious follow-up, right?
Yeah.
You are looking at a perfectly stable patient, but suddenly you are forced to make a massive high-stakes decision.
Mhm.
And the hesitation you feel in that moment is completely justified.
Because of the underlying mechanism.
Exactly. You know, the sheer pathophysiological force of a coronary vasospasm.
Mm.
The mechanism isn't, it's not a simple stable plaque. It is a volatile hyperreactive vessel. You do not want to be the clinician who inadvertently invites that ischemic cascade back into this patient's life, just by removing the very agent keeping the vessel quiet.
It is intellectually frustrating, frankly. On one hand, you are staring at a genuine, completely valid desire from the patient to minimize their lifelong medication burden. I mean, we preach deprescribing where appropriate all the time.
We do, constantly.
Right. Nobody wants to be tethered to a pharmacological regimen dealing with peripheral edema or bradycardia if they literally no longer need it.
Yeah, pill fatigue is real.
It's very real. But on the other hand, we have the very real, very terrifying risk of symptom recurrence, a recurrence that could, it could manifest as a fatal arrhythmia. Today, our mission is to dissect that exact tension. We are going to explore the gray areas where empirical clinical judgment has to step in, simply because the major societal guidelines, they just leave you staring into an evidence void.
We operate in this modern medical landscape where we just expect definitive algorithms for everything.
Oh, the flowchart.
Right, we all want a flowchart. But when it comes to withdrawing therapy in stable Prinzmetal angina, the map simply ends. To make an informed decision for the patient sitting right in front of you, we have to look really closely at what actually drives our clinical instincts.
We need to evaluate where those instincts might be compensating for a lack of randomized data.
Precisely. And figure out how to safely navigate the underlying biology of a coronary spasm.
Okay, let's unpack this by starting with the baseline, because before we question our default clinical posture, we really need to clearly establish what it actually is.
Right.
And across the board, the standard practice is clear. Once variant angina symptoms are controlled on a CCB, you keep the patient on that therapy indefinitely.
Indefinitely. You just refill the prescription year after year.
Like a security system. If you install an alarm and your house isn't burglarized for 6 months, you don't just, turn the alarm off. You assume it's working.
That is a great way to think about it.
Mm.
And to understand why this instinct is so deeply ingrained, we have to look past the symptom and look at the functional mechanism of the disease.
The plumbing versus the electricity.
Well, more like plumbing versus the walls of the pipes themselves. Prinzmetal angina is fundamentally a problem of vascular, smooth muscle hyperreactivity. It's often coupled with endothelial dysfunction.
Right, so unlike typical angina.
Yeah, typical angina is driven by a fixed atherosclerotic stenosis. That's a demand ischemia. But variant angina is a supply ischemia. It's caused by a sudden, intense reduction in coronary lumen diameter.
Just clamping down.
Exactly. So the calcium channel blockers, specifically the dihydropyridines or non-dihydropyridines, depending on the patient's heart rate profile, they're actively blocking the transmembrane influx of calcium ions into those smooth muscle cells.
They are inhibiting the calcium calmodulin complex from activating myosin light chain kinase. So they aren't just masking a symptom centrally, they are physically preventing the mechanical contraction of the vessel.
Yes.
It's essentially a chemical stent.
I like that.
Right. If you place a physical stent in a ruptured plaque, that's structural. But here, the medication is acting as a chemical stent holding open a hyperreactive biological spring.
The chemical stent analogy captures the dynamic nature of the problem really well, but there is a crucial distinction. A physical stent endothelizes, right? It becomes a permanent structural fix.
Whereas the drug...
Your chemical stent requires constant, uninterrupted serum drug levels to maintain that vasodilation. The smooth muscle isn't cured. It
Mhm.
is simply suppressed.
Wow, yeah.
So the absence of symptoms for 6 months doesn't mean the underlying endothelial dysfunction or the Rocanese pathway overactivation is somehow magically resolved. It simply means the calcium channel blocker is currently winning the tug of war.
So, assuming the underlying pathology is cured just because the patient feels fine is, well, it's a dangerous clinical illusion.
It's incredibly dangerous.
Considering the severity of what a prolonged coronary spasm can cause, I mean, we are talking transient ST elevation, high-grade AV block, VTACH, or a full-blown MI.
Yeah.
Maintaining that chemical stent indefinitely really is the most logical defensive posture.
It is the only posture that guarantees the protective mechanism remains in place. When the penalty for being wrong could literally be sudden cardiac death, indefinite continuation is the shield you rely on.
But if that shield is working perfectly and the patient is begging to come off the medication due to side effects or just pill fatigue, why wouldn't we at least look for the data on tapering?
Well, that's the thing.
This brings us to the uncomfortable reality of our daily practice. Are we refusing to taper these medications based on rigorous, hard proof that stopping is inherently dangerous? Or is it simply a fear of liability and the unknown?
What's fascinating here is that our deeply held instinct to continue treatment is actually challenged by a profound lack of direct clinical evidence.
Wait, really? No evidence?
None. We lean entirely on the indefinite continuation strategy, yet there is virtually no robust randomized controlled trial evidence confirming that a structured taper is definitively unsafe in a stable patient.
That is wild. We are constantly asked to practice evidence-based medicine, but here we are effectively practicing empirical defensive medicine.
Bring that in.
There is literally no definitive proof that withdrawing the drug causes harm in a patient who's been completely stable for 6 months.
None of the scale or rigor we would normally require to write a major clinical guideline, but we must look at the flip side too. There is absolutely no evidence confirming that tapering is safe either.
So it's a two-way void.
We are operating in a complete evidence void. The core decision hinges entirely on weighing a known, highly lethal pathophysiological mechanism against the known, but, often less severe consequences of lifelong medication exposure.
Why does this void even exist? I mean, why hasn't the cardiology community funded a massive multi-center trial to figure out if we can safely deprescribe these drugs?
It really comes down to trial mechanics and ethics. To run that trial, you would have to take a cohort of stable Prinzmetal patients and randomize half of them to a placebo or a tapering protocol.
Oh, I see where this is going.
Yeah, given that the baseline condition carries a real risk of sudden cardiac death, the ethical barrier to deliberately removing a highly efficacious life-saving therapy is immense.
No IRB is going to approve that easily.
Exactly. Furthermore, variant angina is relatively rare compared to, say, typical atherosclerotic disease.
Right.
Powering a non-inferiority trial for deprescribing in this specific population would take years and astronomical funding. And frankly, pharmaceutical companies do not fund trials designed to prove you can stop taking their products.
It is a massive blind spot. And it forces you, the clinician reviewing the chart, into a highly uncomfortable position. You have to consider whether cautious tapering might actually be appropriate for the individual sitting in front of you.
Right, rather than blindly hiding behind the safety blanket of indefinite continuation.
So we have to move from this abstract lack of trial data to a concrete clinical evaluation. How do we actually do that?
Since we cannot rely on a blanket societal guideline, we must evaluate the specific patient factors that meaningfully shift the risk profile. You have to stratify the patient's individual risk of a catastrophic recurrence.
Okay.
There are 3 primary clinical factors you must weigh before you even entertain the idea of adjusting their dose.
Let's go through them. If we are looking at their chart right now, the first thing that jumps out is their clinical history. Basically, how severe were the episodes before we initiated the CCBs?
Yes. The clinical footprint of their disease prior to control is your absolutely most vital piece of data. We are looking for the hemodynamic and electrical consequences of their past spasms.
Right, like did they just have a little pain or...
Exactly. Did the patient simply have transient chest discomfort that resolved quickly with sublingual nitro? Or did they experience syncope?
Oh, wow.
Did their Holter monitor or telemetry show life-threatening ventricular arrhythmias during an episode? Did they suffer an actual myocardial infarction with troponin release driven by a prolonged spasm?
If they have a history of those high-risk electrical or ischemic events, that has to be a hard stop.
Absolute hard stop.
The theoretical risk of recurrence just carries way too high a penalty to mess with the medication. It's like taking the training wheels off a bike. You don't do it if the kid has a history of severe crashes.
That's spot on. If the underlying hyperreactivity previously proved itself capable of inducing VT or VF, you do not reduce the suppression. You keep them on the maximum tolerated dose indefinitely.
But what if the history wasn't a cardiac arrest? What if it was just classic, uncomplicated nocturnal angina that woke them up, but their rhythm remained completely stable?
Then we look at the next factor.
Right, so if they are sitting in front of you saying they feel fine, how much weight do we give that 6-month window? That brings us to the second factor, current symptom control.
We look for absolute, unquestionable stability. Have they been 100% symptom-free for those 6 months?
Not just mostly better.
No,
Oh.
not mostly better.
No.
If a patient reports that they still get occasional mild chest tightness in the early hours of the morning, even if it doesn't require a hospital visit, that is incomplete control.
Which tells you the underlying pathophysiological drive is still highly active.
Precisely. If they are having breakthrough symptoms, it means the rho kinase pathways and the smooth muscle hypercontractility are still actively fighting through the calcium channel blockade.
The chemical stent is buckling a bit.
Exactly. You do not reduce your defensive perimeter when the enemy is still actively testing the gates. Incomplete control is an absolute contraindication to tapering. Only a patient with complete sustained symptom control might allow you to cautiously consider a dose reduction.
Got it. So severe history means no. Incomplete control means no. But even if they clear those first two hurdles, we can't just look at the coronary arteries in isolation. What about the third factor, comorbidities?
This is where we look at the structural health of the vessel alongside the functional health. We are looking specifically for underlying atherosclerotic disease.
Okay, so plaquey arteries.
Right. If you have a patient with existing atherosclerotic plaques, even non-obstructive 30 or 40% lesions, the physical dynamics of a vasospasm change entirely.
How so? Walk us through the mechanism there.
Okay, imagine a healthy, totally compliant vessel spasming. It closes, ischemia occurs, it relaxes, blood flow resumes.
Standard Prinzmetal.
Right. Now imagine a vessel with an eccentric atherosclerotic plaque. When that vessel spasms, mechanical shear stress placed on the cap of that plaque is immense.
Oh, I see.
The focal constriction can physically compress and rupture an otherwise completely stable lipid-rich plaque.
So a purely functional vasospastic event suddenly triggers an acute structural plaque rupture and a massive thrombotic cascade.
Exactly. A vasospasm superimposed on an existing atherosclerotic lesion is a hemodynamic disaster. It dramatically increases the risk of transitioning from transient ischemia to a catastrophic ST elevation myocardial infarction.
That's terrifying.
Therefore, the presence of comorbid cardiovascular disease, especially documented coronary artery disease, heavily favors the indefinite continuation of the calcium channel blockers. You cannot risk a spasm anywhere near a plaque.
You essentially need a perfect clinical scenario to even consider deprescribing. You need a patient with structurally clean arteries, a history of only mild, uncomplicated spasms, and a flawless 6-month track record of 0 symptoms, like a perfectly flat road for those training wheels.
You need all of those safety boxes checked. And even then, there's one more vital element to this decision framework that dictates the final call, and that's patient preference and informed consent.
Because ultimately, they are the ones experiencing the medication burden, right? The potential pedal edema, the fatigue, it is their daily reality.
It is. If the patient meets all those rigorous safety criteria and strongly desires to taper, you can begin the shared decision-making process. But they must fully understand the uncertainty we discussed earlier.
They have to know there are no guarantees.
They need to know that we are operating entirely outside of robust trial data. If they understand the potential for recurrence and you agree to proceed, it has to be a highly cautious, heavily monitored tapering process. It is never an abrupt cessation.
Here's where it gets really interesting to me. We've talked about the strict criteria for when we might consider tapering, but the actual execution is where the rubber meets the road.
Oh, definitely.
If a clinician decides to proceed, we really need to outline the dangerous assumptions that could lead them astray. What are the strict do-nots when managing a Prinzmetal patient's taper?
This is where clinical discipline is paramount. When we lack specific evidence in one area, human nature compels us to borrow data from other areas to fill the void.
Right, trying to find a proxy.
Yes, and in this specific clinical scenario, borrowing data is incredibly dangerous. The first major pitfall is applying evidence from acute or unstable coronary disease populations to these stable Prinzmetal angina patients.
We see this all the time. A clinician will look at the COURAGE trial or the ischemia trial and extrapolate those conservative management principles to vasospastic angina. Why is that comparison invalid?
Because the underlying pathophysiology is entirely different. Acute coronary syndrome is fundamentally an issue of structural plumbing, plaque rupture, platelet aggregation, and acute thrombosis.
Right.
Vasospastic angina is a dynamic electrical and smooth muscle problem. The trials demonstrating the safety of withdrawing certain anti-anginal or antiplatelet therapies in stabilized ACS populations, while they're evaluating a static endothelialized plaque.
Apples and oranges.
Exactly. You cannot take that safety data and apply it to a hyperreactive smooth muscle cell. Withdrawing a drug that stabilizes a static plaque is entirely different from withdrawing a drug that actively suppresses a volatile muscle spasm. Doing so actively puts your patient at severe risk.
It's an illusion of safety based on the completely wrong disease model. What is the second pitfall?
Do not generalize data from the acute initiation phase of calcium channel blockers to justify your tapering protocols.
What do you mean by that?
Well, just because we have robust pharmacological data on how to up-titrate amlodipine or diltiazem to gain symptom control doesn't mean you can neatly reverse engineer that pharmacokinetic data to figure out how to stop them.
How does a clinician responsibly taper without a validated dose-response protocol? I mean, there must be some consensus statement on how many milligrams to drop per week, right?
There is absolutely none.
None.
None. There are literally no validated tapering protocols or specific dose-response guidelines to manage this withdrawal process.
Yeah.
And this lack of data highlights a critical pharmacological risk, receptor upregulation.
Oh, of course.
When you expose vascular smooth muscle to chronic calcium channel blockade, the cells often upregulate their calcium channels to compensate.
So if you drop the dose too quickly, you aren't just returning the patient to their baseline risk, you are exposing them to an artificially sensitized vessel.
Exactly. A sudden withdrawal unmasks a hyper-responsive smooth muscle layer, potentially triggering a rebound vasospasm that is far more severe than their original presentation.
Oh.
You are completely off the map, relying entirely on empirical clinical judgment. You have to reduce the dose at a painstakingly slow rate over months, not days, monitoring closely for literally any breakthrough symptoms.
You might be looking at this patient's chart trying to find some objective measure to justify the taper. You might be tempted to draw an inflammatory panel, look at high sensitivity CRP, or check baseline troponin. Can we use biomarkers to guide this?
That is the third major pitfall. Do not rely on unvalidated biomarkers or provocative tests to make this decision.
So no labs.
You cannot look at a low HSE-CRP or a normal endothelial function test and declare the patient cured of vasospastic potential. Those markers do not predict the likelihood of a focal, completely unpredictable coronary spasm.
Right, it's too dynamic.
The pathophysiology of Prinzmetal angina can be entirely quiescent systemically, right up until the exact moment a localized spasm occurs.
And what about using broader population data? Let's say a clinician looks at a massive registry of variant angina patients and sees that the overall rate of sudden cardiac death or hospitalization is actually relatively low. Can they use that epidemiological reassurance to justify taking their individual patient off the drug?
Another incredibly dangerous trap. Do not use broad hospitalization or major adverse cardiac event data as an excuse to taper an individual.
Because it's skewed.
Yes. Broad registries might show low overall event rates for managed Prinzmetal angina, but that is precisely because the majority of those patients are being maintained on their calcium channel blockers.
Ah, right. It's a self-fulfilling prophecy.
Exactly. You cannot ignore your specific patient's individual risk factors, their unique history, and their unique vascular biology in favor of blended population statistics.
The landscape of deprescribing here is just littered with landmines. Every instinct to find a neat mathematical justification or a proxy biomarker just turns out to be a dead end.
Which is why we have to return to the core reality of the pharmacology and the pathophysiology. We know with really high clinical confidence that CCBs prevent the intracellular calcium influx that drives the vasospasm.
They work.
They work. We know they prevent symptom recurrence and stabilize the endothelium. We cannot empirically say that tapering is safe, effective, or reduces adverse events. We also can't claim that indefinite therapy is definitively superior from an evidence-based, randomized trial standpoint.
But practically speaking.
Right. Given the potential severity of an ischemic recurrence, indefinite therapy remains the safest, most biologically sound default.
So we have to bring this entire complex clinical picture into one focused, practical takeaway for the listener to actually use in their practice. When that specific patient is sitting on the exam table tomorrow morning, asking if they can stop their medication, what is the definitive clinical rule?
The definitive rule is this. For stable Prinzmetal angina patients who have achieved controlled symptoms at the 6-month mark, you continue indefinite calcium channel blocker therapy unless there are exceptionally strong clinical or patient-driven reasons that justify a highly cautious, painfully slow taper with rigorous follow-up.
And only if they meet the criteria.
Right. And that taper is only considered if they have zero history of severe events, absolute complete symptom resolution, and no underlying atherosclerotic disease.
So what does this all mean? It means that while uncertainty is deeply uncomfortable for clinicians who are trained to demand hard data, indefinite by default is the safest harbor we have.
It really is.
It requires you to acknowledge the evidence void, respect the hyperreactive pathophysiology of the disease, and have a very honest, transparent conversation with the patient. You have to explain exactly why the chemical stent needs to stay in place, even if they haven't felt a single twinge of chest pain in half a year.
You are managing a profound risk in the absence of absolute certainty. And while that is challenging, navigating that gray area is the essence of the art of clinical medicine. But if we connect this to the bigger picture, this entire dilemma raises an important question that goes far beyond just the management of variant angina.
It speaks to how we approach long-term pharmacology as a whole. What is the broader implication for our practice?
We have to ask ourselves how much of modern cardiology's approach to lifelong medication is driven by a genuine biologically proven necessity, and how much is simply driven by the fact that the medical community rarely funds robust trials to study the safety of stopping a treatment.
That is a phenomenal point.
Are we practicing truly evidence-based medicine, or are we simply avoiding the liability of deprescribing? The next time you're sitting in that exam room looking at that perfectly stable patient asking if they can stop their medication, you aren't just making a localized decision about calcium channels.
No, you're not.
You are standing right on the frontiers of what we know, and more importantly, what the medical establishment is afraid to find out.